Good evening, guys. I have discussion E for you. We are discussing, for this round, we are discussing what's new in geriatric care, an up-to-date synopsis of what's going on in geriatric care. So here we go with tonight's discussion. The up-to-date section. What's new in geriatrics serves as a curated digest of the most impactful developments in geriatric medicine. It synthesizes editor reviewed updates from clinical trials, guideline revisions, and systematic reviews across multiple specialties. The focus is on practice-changing evidence published within the last 6 months, with the current literature review extending through December 2025, and the page last updated on December 8, 2025 for clinicians, caregivers, and policy makers. This resource functions as a bridge between rapidly evolving science and nuanced realities of caring for older adults, major themes and why they matter, risks and benefit, rebalancing for older adults. A reoccurring theme is the careful reconsideration of long-standing therapies in frail or multi-morbid patients. For example, indefinite antiplatelet therapy after percutaneous coronary investigation, PCI, is now questioned when patients are already long-term oral anticoagulation. Similarly, deprescribing hyperintensives in nursing home residents with limited life expectancy is gaining traction. These shifts reflect a broader geriatric principle: minimize harm and tailoring interventions to quality of life rather than rigid adherence to protocols designed for younger populations. Vaccine effectiveness and prevention. Recent pooled analysis and randomized trials have reshaped vaccine guidance. High dose influenza. Give me 1 second, folks. Vaccines continue to show superior protection in those 65 years. RSV vaccination, newly available for older adults, demonstrates meaningful reductions in severe respiratory illness. Updated COVID-19 formulations are evaluated not only for efficacy but also for durability of protection, guiding shared decision-making conversations about boosters in populations with varying risk profiles. Procedure and intervention reassessments. Evidence from contemporary randomized trials has prompted re-evaluation of intensive procedures, carotid revascularizations for asymptomatic high-grade stenosis, once widely recommended, is now seen through a more cautious lens. Modern medical therapy alone may suffice for many, and patient preference is central. This reflects a growing emphasis on balancing procedural tasks or risks against evolving non-invasive management strategies. Notable specialty highlights: cardiovascular medicine. Trials reveal that continuing dual therapy, antiplatelet plus anticoagulants beyond 6 to 12 months post PCI often increases bleeding risk without clear net benefit. Updated guidance favors discontinuation of antiplatelet therapy in most patients except those with exceptionally high thrombotic risk. Infectious disease. Systematic reviews refine vaccine effectiveness, eliminates or estimates for influenza, RSV, and COVID-19. The Infectious Disease Society of America, or IDSA, revised recommendations for complicated urinary tract infections, emphasizing shorter empiric therapy durations and tailoring antimicrobial choices to resistance risks, neurology, and cognitive health. Observational and trial data suggest anti-hypertensive therapy may reduce dementia risks, reinforcing the importance of blood pressure management in cognitive preservation. Carotid revascularization trials inform detailed decision making, balancing stroke prevention against procedural risks. Rheumatology. New studies clarify diagnostic utility of inflammatory markers. ESR, CRP, platelet counts in giant cell arthritis, improving diagnostic accuracy in older adults. Practical takeaways for clinicians: individualized therapy, de-intensification, avoid automatic continuation of long-term medications. Instead, use shared decision-making to weigh risk and benefit in frail patients. Prioritize vaccination. Encourage uptake of updated influenza, RSV, and COVID-19 vaccines with high-dose influenza formulations for those 65. Reassess procedural indications. Consider modern medical therapy as a viable alternative to intensive interventions like carotid revascularization, integrating patient values into decision making. Integrate cognitive health strategies. Recognize the potential role of cardiovascular risk management in dementia prevention, where the summary comes from, and next steps. This explanation draws from the up to date What is New in Geriatrics page, which compiles recent evidence and guideline changes most relevant to geriatric practice. It is designed to help clinicians stay current while adapting care to the unique needs of older adults. Okay, guys. So that is your E for discussion tonight. I will be on tomorrow for shows. Until then, Gator Wellness. Have a good night, folks.